Hello and welcome to the June edition of the Indian Journal of Anesthesia's Editor's Insight podcast. I'm your host, Dr. Gayatri Shashikumar, and I'm delighted to have you all with us today for what promises to be a fascinating discussion on a topic that's rapidly transforming our field. Joining me are three distinguished guests. As always, Dr. Rakesh Garg, our editor in chief of the Indian Journal of Anesthesia. Along with that, we have Professor Dr. Ayten Sarachoglu and Professor Dr. Kemal Tolga. So both of them are from the Department of Anesthesiology at the University of Florida. Their profound expertise in airway management is clearly demonstrated by their substantial body of work published in numerous scientific journals. Dr. Tolga, in addition to his impressive clinical credentials, currently serves as the president of the European Airway Management Society. And it's a privilege to have such a panel of experts in their fields with us today. Today, we'll be exploring the evolving role of high flow nasal oxygen, that is HFNO, in anesthesia practice. While HFNO first made its mark in critical care, it is now finding a prominent and expanding place in our operating rooms, offering new possibilities for oxygenation and airway management. Now, this shift represents a significant step forward, and it is a topic of great relevance for anesthesiologists everywhere. Our conversation will focus on the broader and increasingly central role of HFNO in anesthesia, where we'll discuss its benefits, challenges, and the future it holds for our specialty. So, whether you're a seasoned practitioner or just starting out, stay tuned as we dive into this exciting development with our esteemed guests. So, Dr. Rakesh, I'm going to start off with you. Could you briefly introduce the topic of high flow oxygen in anesthesia? As a journalist editor, what sparked your interest in this area and why is it relevant to our audience of anesthesiologists?
Thank you, Dr. Gayatri, and welcome Professor Kemal Tolga and Dr. Ayten for this podcast and sparing time to give your expertise and your research work into the field of airway management. And as Dr. Gayatri has asked, when we talk of high flow nasal delivery devices, it becomes important. Now, once we start understanding the physiology of our system, we understand that there is a area where we can store some amount of oxygen, whether we label it as the FRC, functional residual capacity, or we say some amount in the dissolved form. But the other aspect is that the oxygen is also being consumed. So even if we fill those resources where the oxygen can be stored, since the metabolism is going on, it will be taken up. And when we talk about airway management, specifically under anesthesia, there will be a duration of apnea where patient may not be breathing, and hence the replacement by the conventional means is not adequate. And God forbid, if it is a difficult airway and we take a little longer time than expected, and since it is not being replaced conventionally, patient may bound into a low flow, a low state of oxygen in the body, labeled as hypoxemia, which can land up into hypoxia. And this is where we need a device which can deliver. Very conventionally, if we talk about oxygen delivery devices, they were labeled as whatever you say, nasal prongs, face mask, or by closed system that are available with our anesthesia workstation. They can deliver up to 10 to 15 liters. The second aspect is when the patient is under anesthesia, there will be some collapse of the airway, and there may be some collapse of the lung section also. If I have a modality where we can expand them, conventionally it was a positive pressure ventilation or a CPAP or something like this. But when we remove the mask for airway management, that CPAP the portion also goes away. So I need a device which serves both the purpose. And luckily, a device now which is available is the high flow nasal delivery devices, which are being used for this oxygenation. And hence, it is one of the very important device. And if we see the recent guidelines coming from various professional bodies, they are emphasizing on this device to be used in the intubation or peri airway management period, so that not only the oxygen replacement which is being consumed, but the additional benefit, humidified oxygen, also some amount of CPAP that it generates, and the opening of the airway that it generates keeps the airway patent. So we are getting all the benefits that is required for a patient to keep good oxygen reserves along with opening of the airway, and it becomes a boon for management of airway where we anticipate that there could be some difficulty. We may take up long period, so why to look for patient's bradycardia and anesthesiologist tachycardia in such situation? Why not to use a device which sustains, you can say, a continuous delivery of oxygen, keeping the airway patent? And that is what device is HFNO, which is fascinating all the airway managers across the world which want safety, and this device has provided all those aspects. And that's why this editorial came up, wherein we talk about the utility of HFNO. And I'm sure that the guidelines which are coming from professional bodies like SAM, DAS, or even All India Difficult Airway Association, it is being emphasized to be a routine part of the airway management.
Dr. Tolga, could you explain for those who are not very familiar with using the high flow nasal oxygen delivery systems, the basic principles of HFNO or Thrive, as it's popularly called, in the context of anesthesia, and how does it work, and what are the key physiological effects?
Well, Dr. Gatti, first of all, I would like to thank for this nice introduction, and I would like to thank Dr. Garg for this opportunity giving us. Thank you so much, really. Well, first, I would like to start with the history briefly to understand how we started to use inside the OR these high-flow nasal oxygenation systems. Well, the high flow technology was originally developed for the neonatal and the pediatric intensive care in the 1990s. It provided a warmed and humidified oxygen at flow rates higher than traditional nasal cannula, and this improved really oxygenation and comfort of the pediatric patients. And after the early studies in neonates, they showed that high flow nasal cannula oxygenation could be an alternative to even CPAP, or because it reduces the work of breath and low levels of PEEP is required for these patients. So it became more and more popular. And when we come to 2000s, the high flow systems began to be applied for the adult ICU units for the patients with especially hypoxemic respiratory failure. And these devices allowed high flow oxygen therapy up to 60 liters per minute with again heated and humidified air and oxygen mixture. And when we come to 2015, there was a very nice publication from Patel and Nouri. It was published in Anaesthesia journal. And they were talking about the intraoperative use during the apneic oxygenation. So the high flow use began to migrate into the perioperative medicine, especially for the pre-oxygenation of the patients during the induction of anesthesia, in awake fiber optic intubation, and for the procedure sedation, especially for the shared airway surgeries. And the apneic oxygenation technique then became to be used for the laryngoscopy or bronchoscopic procedures. And beginning from the 2020s, we started to use more increasingly in ENT surgeries, difficult airway cases, especially for the obese patients with or without obstructive sleep apnea, and also for the patients who were treated for COVID-19 and having operation. So when we come to your question, what are the basic principles of high flow? First, I would like to go for the principles of apneic oxygenation briefly. The main mechanism for the apneic oxygenation is the aventilatory mass flow. So it's a physiological phenomenon and provided by an air passageway which exists between the lungs and the open atmosphere. So there's a difference between the alveolar oxygen removal from the alveoli and carbon dioxide extraction. So this difference generates a negative pressure gradient up to 20 centimeters of water. And this drives oxygen inside the lungs, into the lungs. So the clinical application of this phenomenon is known in anesthesia practice as apneic oxygenation. So if you are providing enough oxygen on the upper airway, and during the apneic period, by using this mass effect, air and oxygen mixture is coming down. So if you are using the high flow oxygen systems, first of all, you deliver heated and humidified oxygen with high flows, and also you can adjust the flow rate beginning from the room air to the 100% of oxygen, and you are exceeding the patient's inspiratory demand. These are important factors why we use them. And this offers us some physiological benefits, like flushing out the anatomical dead space in the airway, providing positive airway pressure, and improving oxygen by reducing the work of breath, and promotes better gas exchange during these procedures. Also enhances the mucociliary clearance, and as I mentioned, reduces the work of breath. So these are important factors, and at the same time, the high flow can generate about a low level of PEEP as well, like about 3 to 7 centimeters of water, especially when the mouth is closed. So this helps us keep the alveoli open, so prevent the patients from the atelectasis, and improve the FRC, as Dr. Garg mentioned, and enhance the oxygenation. So these are the basic principles. Thank you.
Thank you, Dr. Tolga. Dr. Aiton, Dr. Tolga has already told us about a broad range of patients that we can use it for. But in your practice, what patient populations or clinical scenarios do you find HFNO particularly useful?
Thank you, first of all, for your and the invitation. It's very great to be here. And yes, this is a very good question. Already Dr. Tolga mentioned something, but for my practice, my point of view, I never start any medication, any anesthetic technique without high flow if I have any suspicion for high risk airway management. Difficult airway prediction, if there is, and then I have to start with high flow nasal oxygenation and pre-oxygenation of my patient. This is for which patient? Obese patients, of course. After, if I'm thinking greater than 35 BMI, I have to prepare. Also, obstructive sleep apnea patients, moderate to severe patients. This is for pediatric or adult patients also. And pregnant patients, already we assume they have difficult management maybe, and also some critically ill patients if they have some ARDS and coming to OT for any procedure, anything, even changing to from endotracheal intubation to tracheostomy, we have to take our guard, because this is like us, for us, life boy, and for as we mentioned in our case report, and we completed now our study under review in some of journal, one of journal actually. We are waiting results, and we can use for any robotic surgery, laparoscopic surgery, if we need totally apnea. We can use intraoperatively. We will discuss further minutes. And also, difficult intubation means, as we know, difficult extubation and emergence. And then we have to prepare for this period of time for our patients to gain safety and improve patient safety, actually. And for some different patient populations, like COPD patients or ICU patients coming with prolonged ventilation, intubation, if we have any suspicion for tracheal stenosis, for example, for this or any airway surgery, if we need to share the airway with someone, if we need already awake fiber optic intubation for this, everything I do not want to mention again, and or post airway reconstruction, for example, this is also high risk patient for us, and we need to use, and for sedation outside of the OR, we have one study already under review still for pediatric pediatric patient, pediatric population, and for GI endoscopy, for bronchoscopy, or any interventional radiological technique, if we are thinking about some prolonged procedures, we have to protect our patients in terms of hypoxemia or hypercarbia, and to provide better, sometimes surgical field for surgeons. And we can use for all these circumstances efficiently. We have experience and already published many paper in PubMed, as we know, but still we need something. We will discuss more further research. Thank you.
While we mentioned the different populations that we can use it for, I'd like to ask the three of you whether you have any experience in using high flow nasal oxygen in pre-oxygenating patients who are full stomach for rapid sequence induction.
Dr. Tolga?
Yeah. Yeah, okay. Yes, there are some factors that we should be careful about. One of them is about the risk for the regurgitation, so gastroesophageal reflux. If the patient is not fasted, and so we have to be careful because there's always an aspiration risk. If the patient is actively vomiting, so you have to be careful. I cannot say it's a contraindication for the patient because during the RSA we are using it actually, and but we have to be careful about these things because it allows to allow the air to be inside the gastric area, so it can cause also additional vomiting, additional gastroesophageal reflux. So you have to be careful. When we talk about the absolute contraindication, the airway obstruction, I can tell you about the absolute contraindication. If there's a complete upper airway obstruction, the high flow is ineffective. So because the nasopharynx or the oropharynx is fully obstructed and no oxygen flow can reach the alveoli, rendering the apneic oxygenation useless. Like severe laryngospasm, like tumors, tracheal tumors with complete airway obstruction, or massive facial trauma. I can give you some examples of these. There are also some relative contraindications, or let's say situations where we should use with caution. Basal skull fracture or nasal trauma, there's a risk for worsening the injury. This is important. Or introducing gas into the injured structures may be more catastrophic in this type of patients. And facial or airway malformations, we should be also careful because there's a risk for poor cannulation or asymmetry, or compromised seal reduces the efficacy. And also patients require precise carbon dioxide control is also important because TRIVE or high flow nasal oxygenation systems, they don't effectively remove the carbon dioxide during the apnea. So it is important, especially for the raised intracranial pressure, raised ICP patients, severe COPD patients with carbon dioxide retention, severe metabolic acidosis. For these type of patients, we need close monitoring. It's essential. And high flow may not be appropriate for the long apneic period. So you should be careful about them. I'd like to also mention about the air leak syndromes like pneumothorax or tracheoesophageal fistula may worsen due to the added positive pressure, airway pressure. So we should be careful. And finally, immunocompromised or aerosol concerned patients can be riskful. So because a high flow nasal canal oxygenation can generate the aerosols. So this can pose an infection risk like COVID-19 or tuberculosis or influenza. These are the factors that we should avoid.
So, Dr. Aiton, Dr. Tolga was just mentioning about, the hypercarbia being a problem, especially in children or patients with, raised ICP. So, I want to talk a little about the carbon dioxide buildup during the use of HFNO. So, in your article that you wrote in the editorial and in your study, you used perfusion index and oxygen reserve index for oxygenation, probably because they give a earlier alarm for desaturation than a pulse oximeter. But do you have like how do you deal with hypercarbia? Like, do you have continuous oxygen carbon dioxide monitors, EtCO2 monitors there? Do you use transcutaneous system?
Yeah. Thank you for this excellent question. Actually, you asked many things. First of all, I just would like to tell how to expect the increment of the carbon dioxide. We should know some rough numbers. According to studies like Dr. Pata and Ray published already, every minute 0.15 ml carbon dioxide will be increased during our practice. And that's why we have to be careful, because in 10 minutes, as we see in our patients, after 10 minutes already, this partial pressure of the carbon dioxide level exceed some, if we measure with transcutaneous Kaplan stream, like some, I do not mention any company, but entitled carbon dioxide skin measurement, exceed 50 millimeter mercury. That's why we have to be careful about that. And in their, Dr. Patel and their study for obese patients, for example, they reach 110 millimeter mercury carbon dioxide levels. And after 5 minutes of, application, just I would like to mention 0.15 kilopascal, actually, we have to transfer millimeter mercury, sorry. And that's why this is important. We already expect carbon dioxide increment despite of flushing all that space ventilation aboard by this high flow ventilation, but we should expect this. That's why we need to monitor entitled carbon dioxide level. It could be, I think, very beneficial. We use transcutaneous entitled carbon dioxide monitoring, first of all. Why we use oxygen reserve index? As we know, oxygen reserve index, this is a scale, not any, millimeter mercury. You cannot tell. Or it's from 0 to 1, and it shows us 100 millimeter mercury, 200 millimeter mercury PO2 levels. It's, show us indirectly. And during, for example, pre-oxygenation, we aimed in our study to increase ORI value more than 0.5. We start. If any decrement with this value, we can understand this is showing us PO2 is decreasing. And less than 100 millimeter mercury PO2, it will not show anything to us. All the time it would be 0. But we can monitor the course of this value. This is important. This showing us like, red flag. It's patient started to being hypoxemic. As you know, according to oxygen hemoglobin dissociation curve, and it will, after 96, 95, it will sharply decrease, and it will be decreased. And that's why it's good parameter. Actually, why it's created, it shows us mainly hyperoxemia in clinical setup, like ICU setup, but also we can use it, and I and my team did many studies about this intraoperatively in one lung ventilation. How to use efficiently is an alarm for us for this parameter, and that's why we already had this opportunity in some institution. Of course, low resource setup. They maybe cannot have this oxygen reserve index, but if we have in our clinic, why we don't use? This is also additional, safety for our patients, and that's why. And for perfusion index, already, as we know, if carbon dioxide increase, first of all, it will start some vasodilation, something we are expecting some increment, and then it could be sign for us because it's long procedures we use during retroperitoneal, this robotic surgery, and then already it showed us some information, it will give us some prediction. And of course, oxygen reserve index and perfusion index, PI, cannot replace end-tidal carbon dioxide. Nothing, I think, replace end-tidal carbon dioxide value in our practice. If we would like to talk, it will take many more hours, I think. But already just think about this is physiological puzzle like, and then we just would like to improve safety because it didn't use before us, I think, in intraoperatively. When we start to do this, maybe you will ask later on about our study, but just when you mention, I would like to tell something if you let me, and how to provide patient safety before starting to use. We start with one case, totally healthy ASA1 patient, and we just before this, of course, we worked about this in test lung setup. Any barotrauma, anything can be happen, any complications can be occur, and then when we prove us and it would be safety, of course we try with case reports, and we did preliminary studies, and then we complete our series on this patients population. Yeah.
Can I add something?
Dr. Tolga, yes.
Yeah, yeah. So as Dr. Item mentioned, so we use successfully during the intraoperative period for the robophilic surgeries, and I would advise our listeners to read this editorial. Also, we mentioned this study, this case report, and also the studies coming as Dr. Item mentioned. Yes, the carbon dioxide accumulates even you use intraoperative or outside the operating theater or during the difficult airway intubation or during the airway fiber optic. Yes, the carbon dioxide is increasing when you stop the lungs. But when you ask me, so what's the cutoff time period for this? So how long should we use this? There's no, there's not just one answer. So according to the patient's, your patient's requirements, so you have to determine it. So first we start with 10 minutes. So 10 minutes apneic period, but we realized that after 10 minutes, in most of the patients, even they were ASA1 or ASA2, the carbon dioxide really went too much, more than 50 centimeters of mercury. So we discussed with the surgeons. So our main purpose was to make a surgical field more visible and less harmful for the kidney. During the kidney surgeries, they were repairing, they were performing lithotomy, lithotripsy by using the laser. And when during the inspiration and expiration, when the kidney is moving, the damage risk was higher. So we stopped the lungs, and during the procedure, we use a high flow oxygenation inside the trachea. So I think we will discuss later more. And then we decided and we discussed with the surgeons to keep it about 5 minutes. Because when we keep it 5 minutes, less carbon dioxide, and it was easier to get the normal value after the apneic period. And then we again repeated the apneic periods. So we continued like this. Thank you.
Actually, I would like to add something, if you let
Yes.
me. And can you remember, Tolga, in our first case report, we gradually increased the high flow, like till 120 liters per minute. And despite of this, after end of 15 minutes, we reached 62 millimeter mercury and tidal carbon dioxide level. And that's why maybe practically we can give to audience some idea. Sorry, after 10 minutes, they can assume it will, if we start in normal range of entitled carbon dioxide, of course, obesity or low functional residual capacity, everything, some physiological or pathophysiological changes in patient lungs, of course, or body can change it, but they can assume they will 100% exceed 50 millimeter mercury, especially for patients. It's vulnerable to increased intracranial pressure, something. We have to be careful about that. Maybe did we talk about some contraindication, maybe for laser surgery? It can be used, but actually this is not recommendation. I would like to add for audience, company recommendation. They cannot take this. I believe this also. for with laser, and I cannot recommend to use it because it can trigger some airway fire. In the literature already 4 or 5 case reports published, and I cannot use it. Maybe for diathermy bipolar in coagulation mode and short period of use, like less than 5 seconds, 6 seconds, and then close it. It can be recommended, but be careful about that also.
Yeah, and I would like to thank you also for reminding me the flow rate. So actually, we started the intraoperative apneic period by using high flow rates of oxygen, by using the high flow, like more than 100 liters per minute, and we sometimes reach 120 liters per minute. I think the main reason for this is the effective denitrogenation. So before you start the apneic period, so if you adequately denitrogenate your patient and reaching the PaO2 more than 90%, effectively, maybe 90, more than 95%, so it gives you both to prolong the apneic time, and also it allows you to reduce your high flow rates. So then if you adequately pre-oxygenate your patient, so it means that maybe 70, maybe 80 liters of per minute oxygen flow rate will be enough for your patients. It is also important. Thank you.
So, Dr. Tolga, when we talk about flow rates, you said 70 to 80 liters. But when we do pediatric patients, what is there like a calculation based on body weight or age? Because there's not much found in literature about what are the what is the rate of oxygen flow that should be used in a child.
Yeah, thank you very much. This is really important. I have a personal experience in difficult airway management for the pediatric patients. For pre-oxygenation we use, and also during the procedure sedation cases, we use them. When we look at the indication in the pediatric patients, high flow has been successfully used in pediatric patients for the airway endoscopy, like fiber optic or rigid bronchoscopy. Foreign body removal, also we use this one. Laryngomalacia or subglottic stenosis evaluation. During the sleep endoscopy, also it is used. During adenotonsillectomy, as pre-oxygenation or for the apneic oxygenation during the procedure. For difficult airway intubation and also for the sedation cases requiring spontaneous breathing, as we did. So these are the indications. The goals are here maintaining the oxygenation during apnea, actually similar with the adult patients, delaying the desaturation during difficult airway cases, and minimizing the need for back mask ventilation, which interferes with shared airway also. So actually, when we come to your question, there is no absolute age or weight cutoff again, but most published experiences and the clinical practice that use high flow nasal oxygenation in pediatric patients, the age was elder than 1 month old. So neonates especially usually excluded in most cases. If the neonatologist has an experience in the NICU, of course, they are using them. But for the anesthesiologist, not so frequent. When we look at the weight, higher than 5-6 kg is often practical, lower limit due to the flow tolerance of the patient. When we come to the flow settings, usually we use 1 to 2 liter per kg per minute. And up to the maximum limit is 70 liter per minute in older children. But for small children, 1 to 2 kg per liter per kg per minute is quite enough. So it extends the apnea time during the airway evaluation significantly. And again, the safe apneic period is recommended about 5 to 10 minutes when you use in pediatric patients. But maybe we should keep in mind The children, as you very well know, the carbon dioxide rises very quickly because they have a very higher metabolic rate. And so it is really more safe in short procedures. And we are avoiding to exceed the 10 minutes period of apnea in pediatric patients. And the nasal cannula size is also important. There are specific pediatric sizes, neonatal sizes. We should be careful to using these kind of cannulas for the pediatric patients.
Yes, Dr. Aitin?
Yeah, I would like to add something for Dr. Tolga's excellent explanation. Actually, as an anesthesiologist, we afraid mainly because of paratrauma and also increment of the carbon dioxide level in the plasma, which is, as Dr. Tolga mentioned, because of the high metabolic rates, after 10 minutes, it cannot be prevented. But for barotrauma, and we shouldn't afraid too much, because already this is open system, and with 70 liters per minute ventilation with high flow for adult patient, we can create PEEP-like effect not more than 5 to 6 millimeter mercury, and then for pediatric patient, this threshold may be 5 to 6, and for newborn, 5 to 6, maybe pediatric, the same, 4 to 5, and then it's not too much we expect for a trauma because of this already this cannula cover maximum 50% of the nares, and then it will led to release of the air, and that's why we shouldn't be afraid. In the literature, actually, I was curious about that. Then check smallest patient, of course, newborn ICU setup. They used for 23 weeks of gestation baby, and without any complication, and they prevent intubation in some cases. For example, one Italian study, actually they published, I think 2019 or 17, and they used gestational age lower than 29 weeks or birth weight lower than 1.5 kg babies, and they used 30% FiO2, of course, for this baby to aim maximum 90 to 93% of saturation of the oxygen to protect for hyperoxemic effect of this treatment. And they used 4 to 10 liters per minute and flow. And normally, yes, we are using 1 to 2 liters per kg per minute flow. It's recommended and in the literature, and some company has already their Hamilton different, another one different, some, but maybe 1 or 2 liters per minute differences for each age group. But according to body weight, it's good to use 1 to 2 liters per minute. But for again, in this Italian study, they prevent intubation, and also they prevent reintubation in some babies, and that's why I think we shouldn't afraid to use for pediatric patient in a short, AV procedures or some rescue, or provide good pre-oxygenation for our patients. As an anesthesiologist, we are a little bit, would like to be in a safe side, but pediatric, I'm not mentioning about pediatric anesthesiologists or general anesthesiologists, but we can use actually.
Yeah. So NICU, our NICU also uses high flow nasal oxygen for small kids, especially the preterm ones who've got, chronic lung disease of the
Respiratory
newborn.
support, yeah.
Yes, but I think maybe use it. We should just practice in the adults using high flow, and then think about using in children is what I would probably tell to people who are just about to start high flow nasal oxygen.
Yeah, you
So,
are
Dr.
right.
Rakesh, you've been quiet for some time. So I'm. I wanted to ask you in our earlier discussion when we were talking about the buildup of carbon dioxide, Dr. Tolga and Dr. Aitin both mentioned using transcutaneous, end-tidal monitoring. But in most, we don't usually get that in India, don't we? Like majority of the institutes do not have that. So what do you use as a guide to let you know that carbon dioxide might be building up? Do you do an ABG for all cases? How is it?
I think a very important question. We were discussing about the limitations or challenges of using high flow nasal oxygenation. If we compare it with the conventional oxygenation, one benefit of HFNO is that it do leads to some exhalation of carbon dioxide because there is some ventilatory exchange and there is some pressure gradient. So if you compare it with the conventional oxygen, even if you get a 30, 40 liters by the conventional routes, if you see the literature, they say you can use two sources of oxygen because most of our oxygen delivery is 15 liters or 18 liters. If you combine two, it will give you 35, 40 liters. But they will not cause some amount of mass flow of oxygen, and there will not be a pressure gradient which will lead to diffusion of carbon dioxide and exhale. HFNO devices do have this benefit. Dr. Tolga was mentioning about this. So there would be some acceleration. But second is the selection of patient becomes important here. Now, Dr. Aiton was already mentioning about certain group of patients wherein you have to be cautious. We know that approximately with each minute, maybe around 1 to 2 millimeter of mercury of carbon dioxide is mounted up when there is an apnea. So based on this, we do think in patients who are having some neurological disease, pregnant patient, cardiac patients, we know that this is our limit. So 10 minutes, 12 minutes appears to be safe. So this is one. Second is we have to look for the clinical parameters because mounting on carbon dioxide will have some clinical manifestation that needs to be looked for, and we have to about giving them some other ways of taking the carbon dioxide out. Maybe we can have so-called intermittent ventilation to these patients so that carbon dioxide can be taken out. This is one option. If you are not willing for airway management and putting them on ventilatory strategies, but at least we can ventilate in between for some duration and take the carbon dioxide out and restart on HFNO and complete the procedure. So that technique is possible in certain situations. But definitely now we have to move forward to get some amount of transportaneous carbon dioxide monitoring, though it's not very freely available in our country, especially the Middle East Asian regions, they are not available. But then we have to look into the clinical parameters. We have to select our patients appropriately. Look for the clinical hemodynamic parameters indicating any signs of hypercapnia. And if it happens, we have to abort and look some other procedures, some other interventions, and then restart the things.
Just can I add something?
Yes.
Yes, Dr. Tolga.
Yeah, I totally agree with Dr. Garg. So it is quite important to check and monitorize the clinical findings to evaluate them. And just to keep in mind, during the apneic procedure, in any time when you place a face mask, with the anesthesia machine, you can easily check what's going on in the lungs or what's the entire carbon dioxide rate. So with a couple of manual ventilation, you can also check this. Thank you.
Yes, that's a really good tip that you gave us. Dr. Aiton, did you want to say something?
Yes, I agree, both of them, and it's also improve patients' carbon dioxide level because we can apply some ventilation via face mask, and then we can lower intermittently patient carbon dioxide level. It would be grateful. Maybe we actually, when I listened, Dr. Garg, I remember also we didn't emphasize something about cardiac patient. If patient already has some increased pulmonary hypertension in case of or increased pulmonary vascular resistance, this increment in carbon dioxide level can worsen the situation patient, and it can cause sometimes severe, clinical situation. We have to be careful about that also. Thank you.
Or cardiac arrhythmia is also important.
Yes. So now I'd like to move on to Dr. Tolga and Dr. Aiton, your study on, we've been talking about high flow nasal oxygen, and that's what we are all just beginning to learn and experience in anesthesia. And you have already moved on to high flow tracheal oxygenation. So could you briefly describe your technique for administering the high flow tracheal oxygenation, and what specific equipment do you use? And yeah.
Yeah, I can start if you like. So, thank you. Well, high flow of tracheal oxygen refers the administration of, again, the same heated, humidified high flow of oxygen directly, but this time not by the nasal prongs, directly into the trachea, usually through a tracheostomy tube or a tracheal cannula, rather than the nasal route. So here, this technique is most commonly actually used in tracheostomized patients in the ICU, either during the weaning period or post-extubation period, or in selected surgical or critical care situations. It's particularly valuable in promoting the oxygenation, improving the secretion clearance, and enhancing their comfort. So it is safely used in the ICU, not in the operating theater. Well, we have now first personal experience, first time, with the intraoperative use of high flow systems attached directly to the tracheal tube. So how we use it, which equipments we are using? Actually, we are using the same equipment, same device, high flow nasal cannula oxygenation device. Just we are attaching the system directly to the tracheal tube when the patient is intubated. So here there is a special tracheostomy interface or adapter. You can use it, or with the device, actually three-way T-tube is coming. So we are also using this one. By using this, the pressure is not directly going to the lungs inside the tracheal tube. So there's an opening on the three-way tube, and you can easily lower the pressure to avoid the paratrauma during the use. Here, the important thing is we deflate the cuff of the tracheal tube, or you can use a cuffless tube, cuffless endotracheal tube, to allow the flow around and out of the airway. This is quite important. Otherwise, there may be a risk of paratrauma. This is important. We don't use with the laryngeal mask, so because laryngeal mask plays a lot of space inside the upper airway, so it may be difficult to allow the flow out of the upper airway. So we use this. Of course, you can think about, isn't there a micro aspiration risk because you are deflating the cuff, or a major risk for this? Yes, there's a risk for this, but when you closely investigate your patient, closely monitorize your patient, and keep the duration short, just for the dedicated procedure, it will not be a problem. But of course, there's a risk for especially for the microaspiration when you deflate the cuff. But by this way, I repeat, we are avoiding the paratrauma. So as Dr. Atam mentioned, we are monitoring with the ORI, Oxygen Reserve Index, PI, SpO2, the respiratory pattern, respiratory rate, if the patient is spontaneously ventilating, is important. So the capnograph and the transcutaneous capnograms, they're important. Of course, the temperature and the airway patency, they're all important factors to monitorize.
So, Dr. Aiton, what inspired you to explore this procedure during your robo-euro surgeries, and what potential advantages do you see compared to the conventional anesthesia? So, in our setup, what we do is we give them a general anesthesia, and when the surgeon asks us to stop ventilation, we turn it off to the bag mode, and then we wait for them, and then after some time, as when we're comfortable, or when we feel that this is going too long, we ask them whether we can turn the ventilation on. So uh, what was the advantage that you saw as compared to the conventional anesthesia that we give?
Yeah, thank you. This is also a good question. And why we inspired about this, why we thought about that. Because commonly in some sort of surgeries needs to create some totally apnea time where for exposure of the surgical field should be good by the surgeon, and that's why we need to do sometimes totally complete apnea. But we cannot extend this time for our patients, but all the time before this apnea period we have to use 100% oxygen, and we have some hesitation to have some hypoxemia during this period, and atelectasis also, because we are closing the lungs. This is also another important thing. Of course, we didn't use some patients with severe respiratory, illness. Of course, it's not acceptable also use this method because we cannot be sure, but we use mainly in ASA 1 or 2 patients and without any chronic lung disease patients, because I think one of patient we had a little bit high BMI 36 37, is it right, Dr. Tolga? And then we had some starting some desaturation, and we directly stopped to continue to use, and that's why despite of this high flow, we can have some danger, and that's why we have to first of all choose the right person for this purpose. And why we inspired, because we need sometimes zero diaphragmatic movement, and transdiaphragmatic pressure should be decreased in some sort of surgery like robotic surgery, some pneumoperitoneum for some laparoscopic intra-abdominal, and some vessel anastomosis. They need totally apnea, and we thought, why not we cannot use this, because this is increased our safety, and then we could use. But first of all, as I mentioned, we afraid for paratrauma to cause any problem, and then we depleted cup, and then we attached to test lung, and we did it. And after some couple of trial, we did first patient and then preliminary trial to just ensure patient safety, and after that we did this study, and we had no complication, by the way. And when we compare, it didn't publish yet, but when we will publish, everyone will see we had more better actually PO2 saturation levels for our patients, and less carbon dioxide level also achieved by this method when we compare with total apnea or normal ventilation method, and stop the ventilation and start again with 100% ventilation. I think it should be good for our practice on the future.
So, did you do the whole procedure under HFTO, or would you do conventional anesthesia? And then, when apnea was needed, you shifted to HFTO?
Yeah, we started with, yeah, okay. With pre-oxygenation already during induction, of course, and we started to conduct, standard anesthesia, and then when needed by surgeon, and then we did this. In our case report, actually, we did 10 minutes, but for this case, because they need frequent, apnea period, and we limited this with 5 minutes. And some patients in 9 times, 10 times, we did for a different 5 minutes period to stop, ventilation, and we'll use HFTO technique.
So I just wanted to ask you, like, supposing, also, I don't know if you mentioned this before, but did you find any difference in the buildup of carbon dioxide with your, between the two, like HFNO and HFTO? Was it less with the HFTO as compared, like you said, within the first 5 to 10 minutes, the carbon dioxide starts building up in HFNO? Did the same thing happen in HFTO as well?
Yeah, actually, we saw the same, like estimatedly, somehow the same result, and it was not changed. Maybe you are thinking, maybe if we bypass that space, it will
Yeah,
be
yeah,
better, but we didn't
yeah.
see this. Yeah, actually.
Okay. So I want to ask you. So that's a very interesting study that you've done, and I'm really looking forward to see what your experience has been. Uh, so now I want to ask all of you, based on your experiences, what practical advice would you give to anesthesiologists who are interested in incorporating, high flow oxygen, nasal oxygen in their practice, whether it's nasal or HFTO?
Yes, incorporating the high flow nasal oxygenation or the high flow tracheal oxygenation into anesthetic practice have really some benefits for the patients, for the patient safety, because they significantly enhance the airway management. So they increase the patient safety, I believe, and the perioperative oxygenation is better when we use these systems. However, of course, for the success rate, we should be prepared well, and we should be trained also, and the awareness of both techniques is also important to start or to give care for the patients. First, I think we should understand what kind of physiology is behind this. So, what changes we create during the procedure, and we should be really we should pay attention to this phenomenon that high flow nasal cannula oxygenation or tracheal oxygenation is not a ventilation technique. It's an oxygenation support, and the carbon dioxide clearance during this support is limited. So the carbon dioxide will rise during the procedure. So we should be aware of this first of all. And the second, we have to use when we should use this for which type of patient, and in which type of patients when we use, we should be more cautious, or what are the contraindications like complete obstruction, or more careful in raised intracranial pressure, or the patients with COPD with the carbon dioxide retention, severe metabolic acidosis. So we should keep in mind them that we shouldn't first be harmful for the patient. So what I advise to start with the right, what I advise to the practitioners, so they can start with the right indications. They can start easily with the pro-oxygenation during the denitrogenation period. They can use it, and then they can shift to the apneic oxygenation period. So like in ENT procedures or an awake tracheal intubation process. I also recommend to use the right equipment, because there are different trademarks in the market. So we have to be sure which one we are using, which properties, what is the high flow rate, what is the oxygenation rate. So what are the capabilities of the device in our institution. We should be familiarized both with the cannulas, both with the system and the devices. And also I can advise or simply recommend to create institutional protocols. So if you have the device, so I would go to the head of department and make a simple institutional protocol, like when you use pre-oxygenation, so what should be the oxygen rate? Should we keep it 90%, 80%, or just simply start with the 100% FiO2? And so we should determine the maximum limit. For example, we start with 30 liters per minute with the awake patient during the pre-oxygenation, and maximum we increase with the 60 liters, something like that, according to the capability, according to the features of your institution. So, and also keeping the time limited during the procedure, like not exceeding from the beginning 5 minutes, maybe 5 or 10 minutes during the apneic period, and watch carefully the hypocapnia and monitor as the patient as much as possible. And for the pediatric use, as I mentioned, you can use or start with 1 liter per kg per minute, and maximum you can allow to 2 liters per minute per kg per minute, and avoid to use in neonates, and just use appropriate cannulas. So in summary, I would like them to use these devices, not just tools, because they are techniques to expand your airway management options. So they can think about that. But they should demand the planning, understanding, and the vigilance. And when we use wisely, they offer really substantial safety benefits. So we should keep in mind these things and proceed to use them. Yeah, start to use them.
Dr. Aiken.
Yeah, I would like to contribute something more. I agree with Dr. Tolga. Actually, we have to choose right patient, right indication, and we have to uh, actually educate our team, because this is teamwork. And also, this device should be reachable, available in our OT, just only in some place, storage room, somewhere. No, it's not practical. In case we need this, someone should prepare quickly in any scenario for any patient. And this is not emergency rescue technique, as Dr. Tolga mentioned. For example, we need to know this for central airway obstruction or impossible airway management. This cannot be any, replace as a ventilation method. This cannot be acceptable, and it cannot be cannot replace ECMO, VV ECMO for respiratory support, because if we have severe obstruction and like tracheal stenosis, some patients, and I have a high flow, I can go through. No, we cannot proceed. We have to take some other precautions all the time. We have to have ABCD plan all the time in our mind for airway management. If one plan failed, we have to have another plan. And as he mentioned, and Dr. Rakesh as well, and it should be good pre-oxygenation method for us. We can use it. We use this for temporary short period of apnea time to prevent any hypoxemia, to provide good surgical exposure for patients. But we cannot tell it's a ventilation method. It can be wrong. Just I don't want to cause any misunderstanding in this point. Thank you.
So Dr. Aiden, like I was telling you, it's interesting that you brought up the concept of central airway obstruction, because that was going to be my next question to Dr. Rakesh. Dr. Rakesh, you earlier mentioned the role of high flow nasal oxygen in the difficult airway algorithm. In almost all societies, they recommend the use of it. So do you think similarly in the management of anesthesia for airway procedures, HFNO will likely displace ECMO to a lower rung in the ladder, especially in situations like Dr. Aiden said, when you anticipate a central airway obstruction?
I think interesting question and a challenging question actually. Right now, we do not have a strong evidence to say that it will replace ECMO. So the basic principle is, and it is applicable to our anesthesia practice, that we have to choose the right equipment for the right patient at the right time. And here again, when we say about the airway interventions or pulmonary interventions, we have to be very clear that what for we are using it. There are situations where they are working at the carinal level. We are not sure that we will be able to have intra-field ventilatory strategies for these patients. Yes, in those situations, bypass and ECMO remains a viable option. But yes, this is very important, as we have said, for airway management. This is a very good bridge in case of unanticipated difficult airway, where we buy time to manage it, call for help, and arrange the equipments. I think same principle would be applicable for airway management strategies. HFNO is not a replacement of difficult airway cart. It is one of the component of difficult airway cart. And when we talk a component of difficult airway cart, we have to be ready with other equipments, and we can use it as a rescue measure if we are stuck up somewhere. Majority of time, I have done 2 cases in which I have used it for airway surgery, and we were stuck up. In one case where we were not able to ventilate, we started using HFNO for that, and we could buy some time. And then it was actually in a cardiac anesthesia OT wherein we subsequently took the patient on bypass. So in those scenarios, you have to be ready with those situations wherein we are not very sure we'll be able to give a path where the high flow oxygen can be given. In those situations, ECMO has to be there. Second is many of the airway procedures which are being done otherwise, for example, say cryobiopsies, corings, stenting, HFNO is finding a good role because we can give it at a high flow and it is actually helping. The conventional was the use of jet ventilator strategies, manual jet ventilators, Saunders technique. Probably in those situations, it will be a useful to provide FHNO for these procedures. And they're finding a role into the management of those small procedures. We have already talked about the hypercarbia, about the relative so-called contraindications. But yes, it is finding usefulness. But then we need a good data research that how useful they are and what is that cohort of patients in which we can use this successfully, keeping our difficulty way cut. So definitely, I think HFNO is moving out of the conventional OT to the pulmonary intervention OT to the ICUs also nowadays, to the wards also to as a rescue measure. It is bringing a big horizon for its usefulness. But yes, unless we have a robust data for its utility, definitive utility in multiple case scenarios, we have to use this cautiously. And we also have to understand the limitation of our equipment. And this is a basic principle in anesthesia. We can use any equipment at any place, but we need to understand it appropriately and we need to have expertise. Though we called HFNO does not require expertise, just attach, increase the flows at the FI. That's it, but not actually. We need to understand our equipment well. Once we understand the equipment well, we can put it on the right patient at the right time. And yes, it's a useful tool.
Yes, Dr. Aitin?
I would like to add something for Dr. Rakesh's excellent explanation. Actually, we have one editorial we wrote together, three of us, and about ECMO and in the place of difficult airway management, and we criticize a little bit some guidelines because, as Dr. Garg mentioned, it ECMO cannot be replaced by anything in the case of total airway obstruction. We should be prepared for this. This is so crucial, indispensable, because if we can, no matter we can intubate the patient, if we cannot ventilate, this is not meaningful, as we know this. I put impossible airway management, which is defined by Canadian group and in their last guideline, it's separately. Of course, for this group of patients, we can use for pre-oxygenation, for using ventilatory mass flow, if any place who let some, air passage, we can use it. But for rescue technique, ECMO needs time to candidation and preparation, initiate the pump, something like that. It's question mark still in our mind, and it should be discussed. But for a high flow nasal oxygenation or tracheal oxygenation, this is different concept than ECMO, and then we cannot discuss this is better or this is better. The aim is different. The suitable conditions to use it different, but we have to know, I agree, which device we are using. We have to be familiar with the device, and we have to all the time, if we do something, we have to manage complications as well, even for regional anesthesia, for any tool, no matter we use, we have to be experienced to use it. And yeah, this is a good question. Thank you.
I think it's a very as we conclude, this is a very good take home from all of you all, that it's not only the patient that you choose that's important, but also who's handling the equipment who's important. So before we go forward and use it for really major airway cases where we're not really familiar with it, I think we should all be taking it with a pinch of salt and know the equipment before we jump in and use it. So thank you all for joining in. today. And it was really good discussion about the use of high flow nasal oxygen and another new technique called the high flow tracheal oxygen. So I hope the listeners have, got some invaluable piece of advice and information from all our panelists here. So thank you again, Dr. Tolga and Dr. Aitan, for joining us. Dr.
Thank you
Rakesh,
very much.
would you want to say something to them before we conclude?
Special thanks to Professor Tolga and Professor Aitan for their time. And I acknowledge and appreciate their great contribution towards the anesthesia fraternity, especially with regards to their high level of research they are doing it. And I'm sure that this experience of theirs will be helping the global community to use this equipment more wisely, more safely, and to the benefit of our patient. So, from the Indian Journal of Anesthesia and the whole IJA podcast team, we sincerely thanks to you and looking forward for more collaboration from you and your institute and colleagues towards the Indian Journal of Anesthesia, and looking forward for good research papers to the Indian Journal of Anesthesia as well. Over to Dr. Gayatri.
So, Dr. Aitan, do you want to say something?
Yes, actually, I especially would like to thank Dr. Rakesh and Gayatri to you for this kind invitation and management of this podcast. I enjoy as well. I hope all audience can get some tricks and some information to be useful for their practice. So this is honor for me again. Thank you.
Thank you so much. And to all our listeners, until next time, stay safe and stay curious, like we say on the podcast always. Thank you.
Thank you.
Thank you.